Hey guys, Steve Moran here. Welcome to another episode of Foresight TV. I'm super excited about this conversation. I am talking to Dr. Stephen Pantilat. Help me with the pronunciation.
Yep, you got it. Pantilat.
Pantilat.
As it's
Thank
spelled.
you.
Yeah.
I met him at the ACHA conference in San Francisco a few months ago. He is a palliative physician who has really written the book on it. And it's something we don't talk about, but it was one of the best. I hear a lot of presentations, as you know. One of the best presentations. I'm really excited to get into it right
Thanks,
after
Steve.
this. Hey guys, Steve Moran here. So let's actually start with who you are and how you decided to go into this palliative medicine thing. I sort of think most young people coming out of medical school, I'm not sure that would be the choice.
Well, it's increasingly the choice, which is really great. You know, when I was in medical school here in San Francisco, there was no palliative care. I didn't learn anything about it. The field had just really gotten started, and we didn't have a palliative care service. We didn't have a palliative care team. I honestly, in medical school and even in my residency training, never heard of it. But I was here in San Francisco in the 80s during the AIDS crisis, and we took care of a lot of young people, young men largely, with AIDS who were dying. A lot of treatments at the time. You know, this was early in the epidemic. And the care we were providing without a name was really palliative care. That's how we were taking care of people. We were trying to improve their quality of life and help them live well in the time that they had. And really, that was my education in this area without really knowing that I was doing that. And then as I moved on in my career, I remained really interested in this work and the care of people with serious illness, and honestly sort of helped to develop the field from its infancy to where it is now. And you know, now we have fellowship training. We teach our medical students about it. Last year, we trained 77 learners, medical students and residents and fellows in palliative care. And, you know, people choose this as a career. So it's come a long way.
So let's one of the things I think we need to actually start with, because it's an area that I kind of have confusion. And if I recall, I think I actually asked you this when you did the presentation. Let's talk about the difference between palliative care and hospice. And this is a very personal question because my stepfather is on hospice. He's in his fourth quarter, so we're not super imminent. And in fact, we got a new concierge doctor who says we're going to probably get him off hospice. So
Wow.
But anyway,
right.
I think
that happens.
We're pretty familiar with hospice, but I don't know that we really know in the senior living space exactly very much. I mean, we've heard the term palliative care, but what's it mean and what's the difference?
Yeah, great. So palliative care is medical care that's focused on improving the quality of life for people with serious illness like dementia, like cancer, like Parkinson's disease. And the focus is on improving quality of life. It really focuses in three areas. One is on symptoms, so pain, shortness of breath, nausea, fatigue, anxiety. The other area is in communication about decision-making and helping people make decisions so they get the care they want and don't get the care they don't want. And then also in providing support, and that can be psychological, emotional, spiritual, practical support. So that's what palliative care is. And there are lots of ways to deliver palliative care. You can get it anywhere. You can get it in your home. You can get it in the hospital. You can get it in the clinic. You can get it in a nursing home. Hospice is a type of palliative care. In the United States, it's been defined really by the benefit that Medicare created in 1982. Unlike palliative care, hospice requires basically two things. One, that you have a 6-month prognosis. for get palliative care with prognosis of many years while you're undergoing curative cancer chemotherapy. You could get palliative care, and lots of people do. So it requires a 6-month prognosis, and it requires really a focus on kind of comfort rather than trying to extend life. So it means that rather than pursuing, heart transplant or hospitalization or more chemotherapy, people choose hospice when the focus really is like, I recognize I'm approaching the end of my life. Now, some people in hospice live much longer than 6 months, like your father-in-law. And about 15% of people who enroll in hospice will ultimately disenroll because they've stabilized. Maybe they've gotten better or they've gotten stable.
So when do so let's think about this in the context of senior living.
Yeah, great.
My sense is that we probably, as an industry, do not spend much time thinking about palliative care. And as you're describing it, it almost seems like everybody there, at least once we're in assisted living and memory care, ought to be on palliative care if they're not on hospice.
Yeah, you could make that argument.
So what do you think?
Maybe not in every part of assisted living and even skilled nursing, but I think many people do, and certainly in memory care, there can be a range. But yes, I think, to the extent that people are there with a serious illness, meaning something that's going, the illness that is likely to end your life in some period of time. So if that's cancer, heart failure, that I would, and dementia, I would say, yeah, getting engaged with palliative care is a really good way to ensure that you have a really good quality of life. And as I said, that you get the care you want, that promotes your quality of life, but, avoid the things that you don't want. And, that could be hospitalization. Lots of my patients will say, you know what, Dr. Pantilat, I'm done. Like, I don't need to go to the hospital anymore. It just, I wait in the emergency room. I don't like that. Families will tell me, when the last time my father-in-law went to the emergency room and he got admitted to the hospital, he had terrible delirium. He was confused. He was agitated. It was really just a terrible experience. And we don't want that again. And if that's the case, talking about that and creating documents with your preferences so that people will.
How? Well, you've got some lag here. So if I'm I'm thinking about this, and I guess what I'm trying to figure out is sort of two questions. When does somebody actually say, okay, I'm going to go do palliative care as a senior living leader, executive? How do I help people figure that out? And I know that hospice is very programmatic. Is there a similar sort of program system for palliative care like there is for hospice? I mean, so I'm looking at my stepfather, right? And
right.
we actually have just, one of my complaints about hospice is that when things start things deteriorate, their inclination is to just add more drugs and add more drugs and add more drugs. And so looking at my stepfather, seeing all these drugs, and we're wondering if the behaviors are actually the behaviors seem to be getting worse, and are they actually getting worse because of the drugs rather than because of the progression, right? So we've actually brought in a concierge doctor, and we're going to rework all of that. So I'm getting ready to go to war with probably go to war with the hospice next week as we work on this. But I'm thinking maybe what he really would be better off if he had a palliative, and maybe that's essentially what this does. So talk to me. I'm just trying to figure this out because it's very personal to me, and I think this is something the industry faces.
Yeah. You're describing a pretty common situation. And I think in dementia, it can be hard. Behavioral issues can be particularly difficult, both for the person with the dementia and the family. And really trying to figure out, like, are medicines making it better or worse is a really good question. Sometimes they're really necessary and they're very helpful. And sometimes the side effects And a good physician should be able to help you with that. Hospice does have a focus on people kind of approaching the end of life. And, so it varies. I don't know whether, how much different a palliative care team might be, but certainly kind of talking to people with some expertise in dementia can be very, very helpful. And there are doctors with real expertise in this area, particularly in the behavioral part, that can be exceedingly helpful if those are the issues that are going on. That can be really, really helpful. If you work in senior living, the way people get palliative care is usually through the health system where they're getting the rest of their care. So wherever their primary care doctor is, if they have a cardiologist, an oncologist, a neurologist, it's in that system where you get palliative. Have a palliative care program? Is there a palliative care team that I can see? In most, certainly large healthcare systems, you'll be able to find that. If you have symptoms that you need help with pain, shortness of breath, if you're facing some decisions, if you need some support, that would be a really good way to do it. And for example, we have a close relationship with the San Francisco Campus for Jewish Living, which is senior living. And one of our doctors actually goes there to round and to see patients in their acute unit and in their skilled nursing unit. So I think another way to approach this would be for a senior living center to reach out to a local palliative care program and say, hey, I think we have a lot of people here who would benefit from your that would make it possible for you to come and help us take care of our people here, and perhaps develop some, policies and procedures that will be really helpful. So around advanced care planning, for example, so that there can be more routine advanced care planning, making clear what people's preferences are for care, so that you know what to do, in those middle of the night situations when things can go kind of off the rails and you're trying to figure out, what do I do? Do I call 911? Do we send you to the hospital? Like, what's the response? And being clear about what the person really wants to have happen.
So I think, and I'm not in operations directly, so I may be a little bit off base on this, but I want to talk, we've sort of been talking about the mechanics of all this. I want to talk about the human part of it.
Yeah,
so
that's important.
How do we have these conversations? I know that when we did the admissions with my stepfather, and this was also true when my mom was in senior living, we sort of go through the check the boxes off about advanced directives and those kinds of things. But I don't know that we ever just sit down and talk about we're all going to die, right? And yet we don't talk very much about that. And so I'd just love to have you talk a little bit about how we think about that, how we have those conversations.
Well, let me just say that they can be hard. And I think particularly for family, these are sensitive topics. And, some people are super open about it and just want to talk about it, and other people not so much, because death is sad and is filled with grief and loss. And so I understand why we can be reluctant to have those conversations. And they're often really important, and people have things they want to say. I open these conversations is, look, if you were to get sick in a way that you couldn't talk to the doctors and nurses, who do you trust to make decisions on your behalf? Because, fundamentally, that is something we really need to know. And it's not that hard to imagine that you could get sick in a way where you couldn't talk to the doctors and nurses, right? You don't have to be dying for that to have happened. You could just have to be sick. And then, following up with, okay, you trust whoever, your daughter, your son, your wife, your husband. Okay, what's important to you? What are the things that really matter to you when you think about being sick that way? What makes life worth living? When you think about quality of life, what's the most important part? We often have these conversations around kind of interventions, things we do or don't want. Do you want, do you want CPR? Do you want to be in the intensive care unit? Do you want to be on a ventilator? Those are all potentially important questions as well. But the real question isn't about the quality of life that you might be able to sustain or achieve with those interventions. And so that's where I try to focus. And I think that's the important place to really focus the conversation, because you may not know in the moment whether an intervention will help you. Like if you end up in the ICU and you need some antibiotics and you need to be on a ventilator for a few days, if you got back to your quality of life the way you are now, you'd be like, okay, that's okay. I could do that for 3 days, but you don't know at the beginning. So how will you know? I think the question is like, if that happens and you don't get better, like this is pretty serious and you're not getting better. And the doctors and nurses say, well, here's the quality of life we can expect. And you might say, wow, my dad was super clear. Like he didn't want to live like that, whatever that is.
Yeah.
And then you can use that to guide the care in a way that really is reflecting the values and the preferences and the goals. I think the other thing that's really helpful here is that, without that, it can be very stressful to try and make decisions for other people, and the guidance can be just such a relief for the family members to really know, when I see families who can say, my dad was so clear, it doesn't matter which way they were clear. Like, he wanted to be on a ventilator until, the last possible heartbeat, or he never wanted to be that way. Like both of those, the clarity is actually really, really helpful.
Well, and I think that it changes over time. I will tell you that when I was younger, my 20s, 30s, even 40s, if you had come and said to me, so, okay, you go into this long-term coma, what do you want done? And I would have told you, man, I want you to do everything you can to keep my body alive because my mind might come back.
Right.
Today, no way. Not even. I'm watching my stepfather who's got dementia, and his life the quality of life is not very good. And it's only, there's some things we can do to adjust it to make it sort of better, but it's not ever going to be great. And it's only going to get worse. And this was he was my stepfather. My father passed away about 4 years ago. And he was clearly in decline. He had a broken hip, and he sort of his sort of going from having a pretty good life, mentally very competent, to being passed away was about 48 hours. And that's what I want. That's what I want. And so, but I guess the thing I find myself wondering is, what's it like to die?
Well, I don't know that. I've certainly been at the bedside of people who die. What you described with your dad, kind of a short period of illness after, pretty good quality of life. That's what most of my patients want. Most people actually tell me they want to just die in their sleep. I want to go to bed one night in old age. People have different ideas about like what their last meal contained and things like that. But, that's what so many people tell me they want to have happen, that the idea of illness and decline is really just not great. That does happen to some people, but not most. Most people will have a serious illness, and they will have that illness for months or years, and sometimes for decades. Parkinson's disease, for example, or heart failures are illnesses. Cancer these days are illnesses you can have for a long time, for many, many years and decades. And so that's the most likely thing to happen to most people. And then at the end of life, what typically happens is that, the body starts to shut down. It's like your universe just kind of gets smaller and smaller. That's what we notice. And people, that's what I tell people, like, it's like your body shutting down. Like you eat less, you drink less, you move less. it's just like like your whole world is just kind of shrinking down. And I think if you're lucky and you have good care, like you're getting hospice care, palliative care, you can be comfortable, you can have dignity, you can have peace, and fade. Every so often, it's not like that. Every so often, despite our best efforts, people can be agitated. They can be very short of breath. They can have a lot of pain. Those are very difficult, agonizing situations where we really try our best to create peace and comfort, but there are times when that doesn't happen, and that's really hard.
And I think it's really hard for families. I was with my father in the hospital when he passed away, and we made the decision. His decisions were clear.
Yeah.
His wife decision, and he was having fluid buildup in his lungs, and he was on so much medication that he wasn't really conscious. But I would sit in there and I'd hear the gurgling, and it's just like, oh man. And I don't think it was much harder on me than with him. Mm-hmm. And, his passing just, his breathing changed. And I figured he was in for the night. I was sleeping in one of those hospital chairs, and his breathing changed. And I jumped out and took his hand, and there was this little shudder, and he was gone.
Wow.
And so, and it was, sort of weirdly, it was weird to me because in some sense it was very emotional. It was kind of like not very emotional. And I still am not sure I fully processed that. I'm sure you hear stories like that a lot.
Yeah. It's profound, to be there at the end of life. It really is profound. Like there is a real, it sounds almost trivial, but there's such a difference between being alive and not. It's like a huge moment. And as you describe, it's like not when you actually watch what's happening, it's like it's not like some big thing happens, it's just their last breath. And yet it's just deeply profound and meaningful. For a lot of people, it is very meaningful to be there, at the very end. And so I tell people, look, if that's important to you, and it is to some people, then you should be at the bedside like you did, Steve. Sleep at the bedside. The other thing I tell, because the other thing we see is that, you're at the bedside for 23 hours and then you take 1 hour to go, take a shower or grab lunch. And that's when your loved one dies. And it's almost as though they've chosen that moment when they're alone because it's too hard to leave you, or they don't want to put you through it. And that happens more often than I would think statistically would be expected. Yeah. And there's a lot about this that is just, mysterious, and I think inexplicable. And so, just to accept it and to recognize that it's not like you abandoned your mom or your dad at that moment. It's like maybe they chose that moment because it's, it's hard and it's sad.
Yeah, I'm really glad you said that because when my mom passed, I was in a care home, and I was actually in my car driving to go see her. We had no idea that it was imminent. I mean, she had a stroke, and so we knew it was coming in the next 6 months, but that particular day, and to add to the guilt, I'd actually gotten a call, and I'd stopped for about 20 minutes to take this call in my car. And it's like, I still think, man, if I'd been there, I might have been able to hold her hand when she went, but you just don't know, right?
Look, that's the thing. It looks like everything's under control and we can predict when it's going to happen, but we really can't. I mean, we can give, time frames, but we can't. And your story is so common, Steve, where things look super calm and very stable, and then something happens suddenly. And so this is something I tell people as well. When people are really sick, things can happen suddenly. We expect them to kind of happen in a predictable way, but things can happen suddenly, and there may be a reason for it. I think that's also a reason, like every time you leave, to say like, hey, Mom, I love you. I hope, I'll be back tomorrow, next week, whatever. I love you. And, to say those things repeatedly, which, I'm sure you did.
Yeah, I like that a lot. How do I have, I mean, I guess some people like to talk, or I don't know, like is the right word, but are really open about talking about death and dying. So again, I'll come back to my stepfather. He's
Yeah,
93, deep into dementia, but he doesn't really, he doesn't want to talk about death and dying at all. I mean, we've had sort of, I know what his final wishes are, and
great.
no CPR and some of those kinds of things, but we sort of had to force that. Do you have thoughts about how we have uh, sort of, it sounds almost too clinical, but how do we have optimal conversations about that, about death and dying?
Well, I think, look, if dementia is a specific case where it just may be hard to do.
Yeah.
I think as people become more impaired with their dementia, it's just hard to have those conversations, and probably not worth it. If
Yeah.
it can just be more upsetting than helpful, and I'm not sure what you'll get out of it. So I think there it's a judgment call on whether someone has the cognitive capacity to really have those conversations.
Yeah.
I think otherwise, um, I think sometimes the better question is like, that I ask people is like, when you look to the future, what do you hope for? What do you still hope can happen? And, what do you hope for and what's important? I recently had a patient who said, well, there's no hope for my disease, and I just see no hope. And I said, well, when you think of the future, what do you hope for? And she said, well, I hope to have more time to spend with my grandchildren and my children. I'm like,
Yeah.
okay, well, that's important. Where are they? How do you spend time with them? It's hard, if it's hard for you to travel, can they come visit you? And how do you think about that and how you spend your time? And, so there's no hope maybe for a cure, but there's still a lot of things that we hope for. So I think that's one thing that's really valuable to talk about, is kind of what people hope for. What at this point, again, people have different ideas about what's most important to them, what they most want to still do. There are things called ethical wills. We think about wills as a way to distribute our things after
Yeah.
we die, our money, our home, our books, whatever. But there are ethical wills, which is a way of sharing our thoughts about what makes a good life and what makes life worth living, and the lessons that we've learned as a legacy for our family. And, you can look these up, but, it's questions like, what matters most in your life? What lessons did you learn? What are the secrets to a happy life that you've learned? If you were going to give advice to, young people from your vantage point, what would you say? And engaging with loved ones in that way can be really powerful, very meaningful, and you learn a lot about people that you may not know. Of acknowledging their wisdom, their experience, but also thinking about issues around legacy, which are really important. What will I be remembered for? Who will remember me? What did my life amount to? And some people, have a lot to say there, and some maybe think, oh, it didn't. And then, but when you actually start asking them, you learn that, in fact, there's a lot there that people do want to share that can give them a sense of meaning and purpose, but also really help their family learn things that are really important to them.
So I have a theory, and I'd like to try it with you. I don't know whether this is true or not, but I guess I think when somebody is that in those last few weeks or months of dying, that they're probably more willing to talk about the process and the sort of what they're thinking than maybe families are. Is that so? I'm going to ask. I want to just check and see whether that's a reasonable proposition, or maybe that just for me projecting where I've been with my loved ones.
I think it goes both ways. I think sometimes the family is just desperate to talk about. I've seen it go the opposite way, where the person really wants to talk about it and the family's like really uncomfortable even imagining that. And part of our job, I think, as a palliative care team, and I should say that, we really do practice as a team. So I work very closely with social work, nurse, chaplain on our team. I talked at the beginning about what we do in palliative care, and part of it is, providing emotional, spiritual, practical, psychological support. And so much of that is way beyond what my expertise is as a doctor, and yet really essential for people, for bringing families together and for helping to provide practical support around caregiving, for example, or other resources that people need. So there's a lot in there, and some of that is facilitating these conversations. It sounds like, your dad has been telling me there's a lot he wants to be able to share with you, but it's been really hard to have this conversation. And I'm just wondering if you could share a little bit about what makes, other than the obvious that it's just too hard to think of your dad being sick and maybe not being here and dying.
Yeah,
and then it can go the other way, too.
Yeah. So we're about out of time, but I want to get, so what's one thing that particularly senior living professionals, as you interact with them and you look at how they interact with both families and residents who are approaching their last days, what is it one thing that they miss or they could and should be doing better than you typically see them doing?
I think engaging with palliative care and hospice is really, really essential. What we know is that palliative care not only helps people live well, but it could help them live longer. In studies in people with cancer, there's studies that show that people who get palliative care live longer than people who don't. So we always think that, oh, I don't want to trade away, I want to live long, so I don't want this care. That's not true. And so I think reaching out, if I'm running senior living, I think reaching out to my local hospice agencies and to finding where the palliative care teams are and thinking about how we can partner together is a way to actually honor life and really help people think about how can I have the best quality of life. And there's never been a study that shows that people in palliative care live less long. So they live as long and they live better with a better quality of life. And I think it's not only and their family, but it is a way to also support staff, to recognize that, as you said earlier, Steve, death is a part of life. That is a reality, and that there can be ways to, integrate that into the life of our community, and to recognize, if someone dies, let's celebrate their life. Let's talk about them. Let's talk about what happened rather than trying to hide it and pretend that it didn't happen. And so trying to, as much as possible, just normalize what is normal in the world.
Right. I love this so much. And I think that one of the things that sort of is rattling through my head right now is that part of what makes life so precious is that we do pass away, that it doesn't last forever.
That's also true.
So, so I could talk for another hour on this. I appreciate that so much. Before we go though, where do people find you? What resources do you have for them?
Yeah, so I'm on LinkedIn, Steve Pantilat. If you have my name, you'll find me on LinkedIn. You can go there. You can come to the UCSF Department of Palliative Medicine website to learn more about palliative care and what kind of the work that we're doing. My book, Life After the Diagnosis, available anywhere you get books. And if you want to see a film about palliative care, there's a Netflix documentary that was nominated for an Academy Award called Endgame. That's features my team. I'm in it. My team is in it. And it's a compelling story that will teach you more about palliative care. And I guess the last thing I'll say, Steve, just on your point is, I totally agree with you that I think that the acknowledgement of death is a way that we can really live our life fully. And I think that's the other advantage here, is in thinking about that life is limited. How we spend it, who we spend it with, what we do really matters because it's not forever. And I think for all of us engaged in this, that's a reminder that life is great, and to be both grateful and also to think about how we spend it.
Perfect. Stephen, thank you so much. Hang on
You
for
bet.
just a minute after
Great.
we're off the air. And this has been a fascinating, valuable
Thank you.
conversation.
Super. Thanks a lot, Steve.